St. George's. So I'll be talking a little bit today about the history and the examination when it comes to patellar instability. And exactly as Sam alluded to, when you're faced with the patient in front of you, looking at their limbs and how their movements fit into their life and everything that's going on, all of that biomechanics stuff, we have to have a very straightforward way of evaluating and applying. So the presentation of patellar instability, broadly speaking, the patients can come simply with pain without a dislocation. They can come with some giving way, a sense of something not quite right in the knee, or they can come with the patella having been clearly dislocated. And we start with the history. What do we ask them? Well, which knee is affected? And clearly, often it's not one, it's both. Was it a dislocation? Is it clear that it was a dislocation? Is it a feeling of instability, or is it a feeling of pain or unease and distrust in the knee? And then crucially, when was the first dislocation? I think increasingly we're recognizing that the patients fall into a few different groups, and certainly there seems to be a group of patients who present at age around 14 or 15. They're often the more hypermobile patients. And then ask about the reduction, and the reduction of the dislocation is particularly important. So if you ask a patient, what happened, they say, oh, well, just pop back in. Well, that could mean anything, couldn't it? Maybe they've had a meniscal issue and that's reduced when they've extended their knee. Maybe it was just some sort of loose body, painful click, who knows? But if they tell you they went to a hospital or they were seen by a paramedic and they were evaluated and the patella was seen to be dislocated and the leg was extended and it was pushed back and they felt it pop back in, well, that's quite different, isn't it? You've got a pretty firm idea there that the patella was in fact dislocated. So you want to know how often the process this is occurring. Vipul alluded to the fact that a number of the patients will re-dislocate, and indeed they will, but still there's that around 30% who have that first dislocation and really have no further problems with their knee at all. So you want to get an idea of the quantity and the severity of these issues. Have they done their physio? Not just have they been referred, have they gone, have they actually done the physiotherapy? And you need to do some digging around that. Are they known for their hypermobility? Often they'll be known amongst friends and family for the fantastic tricks they can do with their fingers and knees. And other joints. Sometimes you might come across patients who've had dislocated shoulders or other issues, and family history. Frequently, there'll be a history, not only patellar instability, but they may start talking about patellofemoral arthritis in their family, which again, maybe that's another clue to instability. Maybe it's just a clue about hypermobility, but it's worth bearing in mind. And I put birth history in there as well. So I do sometimes ask about birth history, just because there have been some publications where breech presentations seem to have some association with trochlear dysplasia. It's certainly not a strong correlation and not something that's crucial, but it's just something it can be interesting. And then you really need to start figuring out, how does this fit into life? How does it affect the activities they enjoy? Is it the sports? Is it their hobbies? Is it affecting their job? And then finally, really try and work out, what are we trying to do here? Are we trying to solve a short-term problem? Are we trying to solve an instability problem? Are we trying to solve a longer-term problem? And what are their expectations? Are they hoping for a normal knee? Are they hoping to prevent other problems, to prevent arthritis in the future? Because really, all of our treatments, the evidence base for them is for the short and medium term, not really for the very long term. And that's important to consider in the consent. So then we move on to the examination. And first of all, we really want to ask ourselves, have we got the right diagnosis? And then as we go through the examination, we want to bear in mind throughout the whole process, what is going on here? What's the cause? Is it a bony deformity, which Vipul alluded to somewhat? Is it a collagen issue, the hypermobility, or has there been a specific ligament injury on one occasion in an otherwise normal knee that has torn a ligament, and now you've got a problem? And really, there's often overlap of these issues, and there are a few publications that show that to us now, but I would bear this in mind throughout the examination. So first we need to confirm the diagnosis. Hopefully we've done that largely with the history, and we'll get to some more with the imaging later on in another talk. But patellar apprehension is a particularly useful examination. It's fairly specific. You're unlikely to have significant positive patellar apprehension findings in patients with other diagnoses. And then probably one of the most important examinations when it comes to patellar instability is to really take the time to examine the ACL. And why would we examine the ACL, you might wonder? Well, you think about the acute presentation of patellar instability, the acute presentation, a person maybe is hypermobile, maybe playing sport, they twisted, their knee collapsed, their knee swelled, their knee is painful, they attended ED. Very often, the initial diagnosis will be wrong. There'll be, and we've often seen patients labeled as ACL when it's patellar dislocate, first time patellar dislocation, and vice versa. So just take the time to really go through all of your ACL examination with great care. Next, the knee appearance, you may see some bruising, swelling, if it's a recent injury, muscle wasting in the longer established issues, and of course, stiffness as well. Evaluate the stance. I won't go into this in too much details. We've covered some of this already, but valgus is more commonly associated with instability. Genu recurvatum. So you can have true recurvatum, or it can just be a feature of that hypermobility. And it's interesting when you go to do your Baton score that sometimes maybe the Baton score is not abnormal, but hang on, we've got 10 or 15 degrees of hyperextension at the knee. The rotational profile is probably important. There isn't great evidence out there that that's a causal link for patellar instability, nor that there's any surgery that has been described with any substantial follow-up where we would utilize commonly to resolve instability, but you should assess it. Single leg squat is certainly helpful as a dynamic assessment. And of course, look at the whole leg there, and pes planus, flat feet, can contribute to the valgus and again to the instability issue. And then you can start performing specific examinations of the patella itself. Just how mobile is it? There are surgeons who like to describe exactly how many quadrants you can move the patella from one side to the other. It's not something I find makes a difference to the treatment, but it can give you a helpful indication of how mobile it is and start getting your head around the idea of those three things that I discussed earlier. Oh, I'm stuck. And then you need to assess for hypermobility. We use the Baton score very commonly. It's certainly the most commonly used worldwide. I'm not convinced it's a brilliant score, and frequently it's surprising how incongruent the finding in the knee is to the other findings. But it's certainly worth doing, and it's very, very straightforward. And a score of 6 or 9, defines your hypermobility. And then patellar tracking, and tracking, assessing tracking is a sort of a dark and mysterious art. And I'm never quite sure how much, again, it actually contributes to the decision making. I think with the presence now of MRI on a regular basis, it's not going to likely change your decision around surgery, but certainly it's interesting. And you can see sometimes some very significant J tracking and extension, and occasionally more instability and flexion, which again is an interesting finding. And then finally, if you really start going into it, there are some helpful patellofemoral scores out there, and catastrophizing scores and various pain scores, which can be helpful, but probably more in the research setting. So thanks very much for listening, and I'd like to thank again Caroline Hing for helping put it all together.